Hi, this is Elliot Fishman, and welcome to the July 2026 CTisus quiz. I have 10 excellent cases to share with you, so let's get started. In this patient with a drop in hematocrit, what's the best diagnosis? Well, if you look at these two images through the upper abdomen, you see the liver, you see the spleen, you see the aorta. It's arterial phase. And what you can then see on the image on your left, which is the arterial phase imaging, is some high-density structures in the stomach. And when you look at the venous phase, those high-density structures are not as bright, but they're larger. That's active bleeding. Now, sometimes you get fooled in the stomach. There's some retained food matter, but it's going to look the same on arterial and venous phase imaging. Here, the difference in density and the expansion is consistent with the bleed. So when we look at the best diagnoses, I don't see a mass, so I don't see gastric cancer, but I could be missing it. This is not foreign matter in the stomach. It doesn't have the look of an AV fistula. It's a definite bleed. And so for the best diagnosis, this was in fact a gastric ulcer. If you said it was a gastric cancer that bled, I would think about that, but I don't see a mass, so A is the best diagnosis. In this patient with chronic back pain, the best diagnosis is, well, when you look at the images, they're non-contrast scans, but you see paraspinal masses or a mass surrounding the spine with some bony destruction. And then when you look at the sagittal view, you really see the multiple vertebral bodies that are destroyed, the disc space involvement. This is not the look of osteoarthritis because you wouldn't have the soft tissue mass. It could be E. coli osteomyelitis, but that's usually one disc space. Lymphoma is a thought only because you have a paraspinal mass. Maybe it's adenopathy, but lymphoma can involve vertebral bodies, but usually does not involve the disc space. The most likely diagnosis with this kind of deformity is Pott's disease, or TB. If you said E. coli osteomyelitis, it's a reasonable thought in the differential diagnosis, but with this really unusual appearance, it's kind of classic for thinking about TB and Pott's disease, and that occurs most commonly in the thoracic spine. In this patient with fever and right lower quadrant pain, the most likely diagnosis is, well, when you look at the axial view, you see a soft tissue mass which looks in all likelihood like the appendix. And when you look at the coronal, you can see the appendix really is inflamed. There's a lot of inflammation around the gland. The gland is thickened. This is definitely not a normal appendix. It's not the look of ischemic bowel. The vessels look okay, and the small bowel looks good. We're dealing now with enteritis. Again, we're talking about the appendix. And this was a case of necrotizing appendicitis. The patient underwent an appendectomy and did fine. In this patient with abdominal fullness, the most likely diagnosis is, well, when you look at the axial and the coronal view, you see a large soft tissue mass in the mesentery extending toward the retroperitoneum. It's fat density. Now, mesenteric paniculitis gives you fat density and swirling, but doesn't have such a mass effect, and this has more of a capsule appearance. It's not lymphoma. Lymphoma is solid. This is fat. It could be a liposarcoma. You would at least think of that. That's not one of the possibilities. It's not sclerosing mesenteritis. There you typically have a solid mass, often with calcification. You don't have this much fat appearance. So the best diagnosis here is a lipoma of the mesentery, which this was. Now, again, as I mentioned, when you see a fatty mass, the most common retroperitoneal malignancy is a liposarcoma. So if you said to me, I didn't give you any choices, what's a possibility? I would say lipoma, but I would want to make certain I wasn't dealing with a liposarcoma. In this patient with jaw pain and swelling, the most likely diagnosis, Well, you see a large lesion expanding the mandible, its soft tissue density. I would love to see the 3D in this case. In fact, this was published in DII as one of their cases. It could be an aneurysmal bone cyst, but the soft tissue density inside makes it unlikely, and it's not a great location. You don't see periosteal reaction, so osteomyelitis or radiation-induced sarcoma is not going to be a possibility. With radiation-induced sarcoma, you see sclerotic changes, bone destruction, similarly in osteomyelitis as well. Here, the best description, particularly on the image on your left, is the expansion of the mandible, and that's really classic for melioblastoma. A very nice case. There's no adenopathy. The patient will get surgery, and the patient will do fine. They'll then put a bony graft in place. In this 11-year-old, the best diagnosis is, well, you see a large left renal mass, there's para-aortic adenopathy. Now, in an 11-year-old, you're not going to see clear cell or papillary renal cell carcinomas. Wilms is a good possibility, right? Wilms tumors, but that's typically age 5. Renal medullary carcinoma is an older, more like teenagers perhaps, but it's also typically seen in patients with sickle cell disease. This was renal medullary carcinoma, one of the pediatric renal tumors, but again, if you said Wilms, I'm going to give you full credit. In this patient with back pain, the best diagnosis is, well, when you look carefully, the image on the left, you see the aorta is narrowed and the soft tissue surrounding the aorta, and a little bit lower the aorta is occluded. This is not a poor timing. It's a good injection. You see how bright the aorta is. It's not septic embolism. You could think about lymphoma, but that doesn't occlude the aorta, and it would be probably treated lymphoma. Lymphoma involving the aorta often displaces it off the spine, and it's much more bulky. This is a classic case of retroperitoneal fibrosis. Soft tissue encasement can involve the renal veins and ureters, contracting them, but also occlusion. There's a number of causes of retroperitoneal fibrosis. We could not find a specific cause, like IG4 disease or other vasculitis. There was no medication involved. This was felt to be idiopathic retroperitoneal fibrosis. The most likely diagnosis in this case, well, we see a large mass in the tail of the pancreas. The mass, as you notice, has multiple septations. It's cystic. It's not the look of an IPMN. Spens are typically more cystic. Mucinous tumor, again, is more cystic, often has calcification. When you start seeing septations, you got to be thinking about serous cystadenomas. They more commonly are in the head of the pancreas, but can occur in the tail. IPMNs are usually patients in their 60s. Spens, women in their teens and 20s. Mucinous tumors, women in their 40s. And serous cystadenomas, the patients are in their 60s or 70s. Serous cystadenomas are benign lesions. This was a serous cystadenoma. The most likely diagnosis in this case, you see high-density material in the subcutaneous tissues in the buttock region and in the patient's thigh. And although we're focusing on the right side, you can see the high-density material is often also seen on the left side. This is not contrast extravasation. That would look different. This is not a prior lymphangiogram because there's no lymphatics. This is in the subcutaneous tissues and by the fascia. It's not cellulitis because cellulitis is not high density. This is a classic example of dermatomyositis. That's its look, high-density material. You can see high-density material in injections. We see that in the buttocks sometimes if patients who get unusual procedures, but not this high density. This is typically, classically, going to be dermatomyositis, which it was. In this patient post-trauma, the key CT finding, well, you can follow the images down. This was a CTA. You can see foreign matter in the soft tissue and muscle. You can see air in the muscle. When you look at the coronal, you see the superficial femoral to popliteal, and then you notice the three vessels, posterior and anterior tibial artery and perineal artery, and you see from the region of the perineal artery there's a high density blush present, and that blush is active contrast extravasation. That's the key finding here. The patient did have some bony fractures, which are not well shown here, but this is a beautiful example of active contrast extravasation. Well, those are 10 cases. I hope you found them useful. I hope you got them right. But more importantly, I hope you learned something. And with that, have a great day. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at CTisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.